Let's start off with a few case study. So we have this Madam O.S.T. She's a 75-year-old, premorbidly with hypertensive, type 2 diabetes, dyslipidemia, but she's independent, very good 75, still walking, cooking, okay, for the grandchildren. Okay, very short history, 2 days of poor appetite and then increased spitting. So why is it spitting? Later we'll discuss why actually we put the term as spitting there. And then upon arrival in our emergency, she looked confused to place and people. She was dehydrated, mildly tachypneic. When I say mildly, maybe the respiratory rate about 22, 24 only. Okay, not that bad. But we can see that she's a bit tired, and then there were crepitations on bibasal lungs. Okay, so in elderly, you have bibasal crepitations. Very difficult lah, kan? This can be anything under the sun, very common. It can be orthostatic, it can be heart failure. Of course, you know, it can be some atypical infection. So, but her oxygenation is fairly okay, 95%, okay? So, of course, we put her on oxygen because she's tachypneic. We don't wait until she's fully hypoxic before we put her on oxygen support. So, we'll discuss on her case afterwards. We're going to proceed with the second case. There's another one case we'll discuss afterwards. Mr. and SL, no medical illness before. Okay, early 50s, very short history, 4 days, fever and cough. Very common, something that we can see every day. So, but somehow on the 4th day, he has progressive shortness of breath, went to ED, and then diagnosed to have acute respiratory distress syndrome. Okay, and then he was intubated, ventilated, and then transferred to Singapore upon family request. Okay. What might come to your mind when you have the RDS patient? What else do you want to know about this patient? Yeah, smoking, right? He's a smoker, yes. If he's not smoking, he is actually a carpenter. You imagine? Yeah, everybody's, oh, okay. So why? Because we assume that he's exposed to all the dust. Maybe it's chemical exposure from all the, painting, okay? So he's a carpenter. And then his admission in Singapore was very complicated. It was prolonged ventilation with tracheostomy. He was there for 2 months and developed heart failure, high pulmonary hypertension because of the pulmonary embolism. And he came to us for rehabilitation in tetraplegic condition. Not talking, on tracheostomy, not moving at all, cachectic like skeleton. Okay, that's how his situation is. Okay, of course he's still on and off on ventilator support, on and off because of the recurrent hypoxic. Later we'll share about his case as well. And then third case, Madam NS, cough for 2 weeks, very common. Started off with fever, first 3 days, flu, phlegm, sore throat, then settled except for the cough. Okay, and then now started to feel tired, poor effort tolerance. Maybe they'll come over to clinic saying that, I'm not really improving, I'm still having cough, but I have no more fever. Also very common setting that we see in the clinic, right? So she looks stressed looking, very stressed. You can see that she's not sleeping very well. She's not breathless, but you can see that she keeps on like this snake, forcing herself to take a deep breath and also always clearing her throat. So her situation looks normal, but then the lungs got prolonged expiratory phase. So when you say prolonged expiratory phase, meaning that there is some tightness of the lungs, okay, the trachea or the bronchus, okay. All right, now we need to know what is actually an oxidative stress or inflammation. We realize that we have so common infection in our clinic setting. We have influenza, viral infection, pharyngitis. Recently we were bound with all these COVID cases. But we realize that some cases doing very well. Some actually very bad. Okay? So we were wondering why is it that some actually responded very well. They don't even have symptoms. And they recover without realizing that they have infection. Some actually end up very bad, like Mr. and Mr. just in the ICU care. Right. So we were trying to find, and then they did the research, and they found out that actually there's oxidative stress that's causing the inflammatory reaction. Okay, so today we just want to know what are the oxidative stress that we are talking about. Mana ni? Go back. Okay. So I know this is a busy slide, but this is going to be repetitive slides later. We just look into this oxidants. Okay, what are the oxidants agents? Okay, when we say oxidants, what it cause stress with our respiratory flow, our tract. Okay, and then we have this oxidant from infection, environmental contaminants, cigarette smoking. Okay, and then when oxidants develop, what happened? It causes the stress and cell damage. It causes macrophages activation. It causes neutrophil activation, epithelial cell activation. Why are all this activated? You imagine if you have a fortress, you have your own house, and then your house got penetrated by foreign people or bad people. Of course, your body will build up, or maybe we can say the body we imagine is a country. Okay, of course, when it's invaded by the bad people, your army will keep on waking up. They triggered the army to wake up. They triggered the army to go out and fight all these bad things. So when your army wake up, what happened is all these other armies that protected the body. So when they have this activation, they need a way to heal themselves after the injury of fighting in the battle. And then afterwards, they go back to the normal function. Okay. So what happened is, when the oxidation happened, they don't have time to recover. Okay. So the inflammatory reaction just keep on going on, so it become a cascade. So it produces more and more macrophage activation, and all this will cause emphysema, this permanent damage of the lungs, and it causes neurogen inflammation, fibroblast formation, scarring. So that's why patients develop chronic bronchitis, bronchiolitis, cell damage by apoptosis, and also can cause the necrosis. Okay, so all this actually the one that causing the hypersecretion mucus, swelling, edema, and also the bronchoconstriction. Right. So we have to understand what this oxidative stress importance that's causing the lung damage. So this is the reason why some patients develop very mild symptoms, some patients develop very bad symptoms because of the reaction of the body. So it's always depending on the individual patient and the risk factor. Later we look into the risk factor. So what are the role of NAC that we're talking about tonight? So this is just a molecular level, just for our understanding, right? It's a synthetic cysteine. So what is important of cysteine? It's actually an acetate group that helps to build up our glutathione, which is in a simple way I put to you. So there's a thiol group which combine in this that causing flumacyl outstanding from the other type of the acetylcysteine. Okay. So this is molecular level. Never mind. We just stay with me first. Okay. So NAC is a booster of glutathione. So they did the study. Okay. I just take example of some research paper coming out in 2022, last year, when they look into all the COVID cases. Then they realized, actually about 70% of elderly develop very bad infection. There's about 40 to 50%, all these comorbidities develop very bad infection, okay, end up in ICU. And then they found out that 40% of cases of COVID actually in young patients, but still develop in ICU. So apparently this correlate with the aging process, comorbidities. So what they found out, they did a very difficult study. They find out how to calculate the glutathione. Okay, our glutathione is our natural antioxidant in the body, right? If we age, our glutathione level come down. If someone is having comorbidities, underlying disease, diabetes, hypertension, our glutathione is actually coming down. So those who have lower glutathione is actually the one actually at risk of having severe infection, right? So where does NAC come into this? So NAC is actually a precursor. And then we need the NAC somehow to improve the glutathione production, more stabilized so it can work better. Some said, okay, apparently this is not really needed. Why don't you just give a high dose of cysteine je ke? Bagilah high dose cysteine. Terus directly can produce the glutathione in the body kan? But it's not safe and it's not readily absorbable. So that's why this molecule is actually works better, more stabilized, and it can produce glutathione on a steady basis. So glutathione calculating is not easy. That's why it's not easily done in a whole hospital. We have to get the sample and then put in the refrigerator, have to cryo first at certain degrees Celsius. It's not easy. Very expensive test, but not really, how to say, not really going to give change of the patient's management, okay? So that's why it's not routinely done unless for the research purpose. So this glutathione, it helps to prevent damage to the cellular components that's caused by the oxidative stress. Okay, so apparently glutathione boosting treatment like the acetylcysteine enhance the immune system and also it reduce the severity of the viral infection, including coronavirus. So that was a study that did in 2022. So on top of that, okay, it also have the anti-phlegm action. So how is it that actually it can cause anti-phlegm production? Because this NAC, it disrupts, okay, the bridges that of the mucoprotein. So it we call it thinning up or dilute the secretion. So easier for the patient to expectorate. And furthermore, it improves the mucociliary activity. So it's actually pushed up. By right, the phlegm should be pushed out easily because this mucus should be a normal mucus, which is a very, how to say, in the same wave, okay, so easier for it to move. But what happens with infection? So infection, it's not here, later. So infection will cause the phlegm to be very complex meshwork. So it's not easily to be pushed out by the mucociliary activities. So this is where the NAC works. It helps to improve the movement, facilitate the mucus removal, and also it helps to dilute the secretion. So study showed this is, they did the study and they compare, okay, easy to say lah, maybe they're already recovering. Why? You say it's actually the flumasil causing it. Of course, when they did the study, when they give 3 arms, flumasil 200, 600 and 1200, realized that this mucolytic effect is fast, within 45 minutes, and also the action, which you can see, the sudden acceleration, and then it lasts longer, okay? And it improves mucociliary separation by 20%. So even after 10 days of the NAC. So, and then the anti-phlegm, apparently it clears phlegm effectively compared to placebo. We can see there's a reduction of the phlegm production. And also it reduces the cough intensity. If there's no phlegm, no triggering factor, you have lesser cough lah. Right, and then airway congestion. This is a good study because it compares the bromhexine and the NAC and also placebo. So this is, but I can say this is a head-to-head comparison because bromhexine also is actually a mucolytic agent. So when they compare this, the purple one NAC with the bromhexine, you can see the big difference. Okay, so the phlegm reduced significantly compared to the bromhexine. Okay, let's go back to our first case just now. Okay, so she's 75 with all this comorbidly coming in. You have to remember elderly most of the time when they come to clinic, when they have infection, they don't have fever. Okay, they only have reduced appetite, poor response, small sleepiness. Okay, they don't really mount fever like our younger patients. So for her, when she has confusion, if we calculate, go back to our medical studios lah, we go back, we look at the CURB score. So with CURB score, we look at the comorbidities, the urea, okay, the respiratory rate, also ada lain background medical problem, okay. Conscious level is also one of it. So when there is confusional, of course this is considered something which is not treatable at home, okay. So she requires a treatment in the hospital. So of course she's dehydrated, we put her on a drip hydration. We were worried that she might have a heart failure because by best reputations, but clinically dry, no pedal edema. We did echo anyway, and then there is no evidence of the heart failure. She's fraction good still. So actually her influenza was positive, okay. So treated for viral infection with dehydration. Of course she has flu and phlegm, acute pharyngitis, poor appetite because difficulty to swallow because of pain. But we covered with antibiotic anyway, okay? Because this is a high-risk patient, sometimes from a lot of secretion, we cover with the antibiotic. So apparently after 2 days of admission, my cut-off 48 hours. If 48 hours not really improved, we have to find out why you're not improving. You should have better appetite now. Why you should still look lethargic? So one thing that I realized, the family members and carer will tell me, Doctor, dia banyak ludah. The carer is an Indonesian maid. Banyak ludah, Doctor, banyak ludah. So apparently when look back, she had a lot of tissue beside her. She's not coughing. But apparently ludah meaning that she has a lot of secretion, but she has no energy to spit it out. And at the same time, because she's not having the reaction, she's not coughing very well. So all this so-called a lot of spitting is actually her secretion. It's thick and she cannot spit it out properly, she cannot cough it out properly. Okay? So we put her, because this happened in teens are expected in a viral infection, we put her on NSC, added on afterwards. Okay, and you see that after only the first 48 hours, okay, her spitting has been lessened, she breathed better, and she looked more energetic, she started to have good appetite, okay. Phlegm is thinner, of course, and she started to cough. So this is the part sometimes I realize my patient, after we start NSC, they start to cough. Okay, it's not that the medication causing them to cough, but because it's more fluid, so they have the energy to cough it out better. Because cough, I tell them, good, you have cough, so your body can actually bring out all the bad things. So it's good that you have cough, you have good reflex, so everything bad will come out. Okay, so start to have cough and then better expectorate. Of course, we put her on chest physiotherapy, and afterwards she was discharged. Okay, so this is one case and evidence of the she has an anti-phlegm effect of this NSC. All right. So what does NSC do? Number 2, it has antioxidant action. So antioxidant again, we talk about antioxidant just now. So complicated slides, yes, but just bear in mind that this NSC, it will cause glutathione synthesis. Okay, glutathione we know that is protective agent in our body, so it helps to produce more glutathione. So, so it helps to restore the intracellular levels of glutathione. So glutathione more, you can fight infection better, lesser injury to our respiratory cells. Okay, and also it have direct antioxidant, which reduce the production of the antioxidant, the oxidant agent. Okay, so it boosts defense systems. So they did a study again, I told you just now, they try to calculate the complicated glutathione in the body. So after putting on NSC, the glutathione level increases, so it helps to reduce the formation of the oxidative agents in the airways and improve the symptoms. Okay, go back to our Mr. NSL just now, the one with the ARDS, okay, and then was transferred over care to GHMJ for rehabilitation. So he comes in oxygen dependent, very cachectic looking, only skin and bone, okay, and then slowly we try to taper off his oxygen support up to the level like we managed to remove, okay, the tracheostomy. So even though with all this optimal medical therapy, regular nebulizer, he's still having hypoxic event due to mucus plug. You know, early on tracheostomy is not easy to take care of. Even though we say, okay lah, tracheostomy easier. It's not easier because it's easily blocked if you don't really take care of the patient properly. Not under close observation, you might not realize patient just stop there, not really speaking, not really breathing. Just blew suddenly and then they develop cardiac arrest. So he has recurrent mucus plug blockage in the tracheostomy. So we did the physio, nebulizer, still thick secretion. So we just start him back on the Flumasil when he comes over. So up till now, actually a few months after discharge, and he is able, this is exactly how he looks like. Thin, but then he started to walk, okay? But with oxygen support, he is on already developed interstitial lung disease, permanent damage to the lung, oxygen dependent. But he's ambulating in the house with the oxygen, okay, and come to my clinic happily smiling away, very happy. Doctor, can I stop my oxygen? No, you stop oxygen, your risk of mortality is higher. So just keep the oxygen, even the oxygen better. We do off the oxygen for the for the interstitial lung disease. Yeah? So realize that every time he's on flumacy, his symptoms get better. And then it lasts longer. After we discharge, he's not really coming back to us if he's on flumacy. Then afterwards, we try to stop the flumacy. Then after we stopped the flumasil, he started to have another new bouts of infection. So we realized that because of the anti-inflammatory reaction, antioxidant agent in the NS, it helps to prevent him from having all these complications. Okay, even though the damage has been done because of the previous infection, definitely this we can help to prevent him from getting another one. Right now, he's come back to my clinic every 3. I think I last saw him 1 month ago. Walking very well, talking normally. Okay. And then definitely improved significantly, right? This is off level. Why I put here off level? Because I'm not so sure how long we can give the flumasil for. But he benefit from the flumasil for a few months already. And I think he was seen first somewhere in March. He was in Singapore since January. So when he comes back to us somewhere in April up till now, I think about 3-4 months already of flumasil. Tolerated very well, no side effect obvious that we can see, and then he still get the benefit from taking the flumasil. So that is for the antioxidant effect. So number 3, NSE have this anti-inflammatory reaction. Okay, so anti-inflammatory basically NSE induce specific anti-inflammatory against interleukin 6. Okay, so this is the reason why the NSE improve the inflammatory reaction. So one meta-analysis international clinical studies in more than 2,000 patients with chronic bronchitis or COPD. So when you put patient on flumasil, it gives the quick symptoms relief. Okay, and then also improve the recovery. We see here NSE group, we give 600 per day for up to 24 weeks is about 3 months. No, 3 months. No, 6 months, right? 6 months. We can see that there is actually improve the recovery rate of not having exacerbation is higher, okay, in the NSE group compared to the placebo group. Next one. Now there's another one, retrospective analysis on more than 1,000 cases, hospitalized patient for acute exacerbation of COPD, of course. And then we can see that the NSE reduced the risk of re-hospitalization by 30%. Okay. So that's how significant the improvement is. So let's have a look. Okay. It has this anti-biofilm. Okay, for those who are wondering what is biofilm, okay, biofilm is actually a formation built up by the infection. It causes irreversible addition to the intimal layer, the internal layer of our cells, and then it will produce this microcolony. And then they build up a complex 3D mature biofilm. So this mature biofilm is not easily penetrated. Antibiotic cannot go in. Okay, no matter how good antibiotic is, if they cannot penetrate the biofilm, the bacteria keep on replicating inside there and causing all this pus formation, cell damage, necrosis. Okay, so what the NSA do? It goes there, it disperses the biofilm. So one is dispersed the biofilm, what happened? Easily break up, so antibiotic can work better, right? So this is how the NSC works in the biofilm dispersal. So it has some good antibacterial properties as well because it interferes with the biofilm formation. So alone or in combination, it can decrease the risk of exacerbations, bronchitis, obstructive pulmonary disease, even allergic reaction, rhinosinusitis. So that brings us to this patient again, Madam NS, commonly we see in our clinic. Cough for 2 weeks after fever settle, not improving, now tired looking, on having difficulty in breathing. She has this feeling like tightness there. So because it has been quite some time, we advise better get admitted. Let's just examine properly. We do the X-ray. And then she has this prominent perihilar haziness. Okay, when you see perihilar, what comes to your mind? Perihilar haziness is actually the atypical infection. Okay, they presented with perihilar haziness only, nothing much. Sometimes we can say, ala, normal je, nothing much, no causative changes, right? So, WBC normal. So, what we usually look at when WBC is normal? We look at what do we look at? We have the neutrophil, we have the eosinophil. What are the things that we look at? Sorry? Sorry? ESR, correct. That one inflammatory. If this is the part, the partition of the WBC itself. If partition itself normal, if eosinophil high, it's because of the allergic reaction. Okay. Neutrophil high is because of the bacteria. If the lymphocyte high, viral. Right. What else do you have there? Monocyte. Yes. Monocytosis, most of the time, if it's high, it almost always is atypical infection. Okay, so atypical infection commonly cause prolonged bronchitis, empty reaction. Asthmatic patient especially will get more vulnerable to have the bronchitis. So, is there any role of antibiotic in her case, even though the WBC is normal? Usually we give. Because of the atypical, we cover with the atypical antibacterial. Should we give nebulizer? So she has prolonged respiratory phase, she feels dyspneic, oxygenation is good. Usually they will benefit from the nebulizer as well. So we give some bronchodilator as well. So we put her on Flumasil 600 BD. Well, sorry. On the very second day itself, after the first 24 to 48 hours, we can see that her secretion, thank you, secretion lesser. We can hear her cough lesser because before that she can't even talk. Whenever she talks, she coughs, she talks, she coughs. So we can't even finish the sentence. So after we start her on the medication, she started feeling better, started to ambulate. You know when we should discharge? Whenever they start to do their work in the hospital. Whenever my patient sit down and then look up laptop and then do their job, I say, okay, it's time for you to go home. Don't wait here. Go home. Okay? There's no danger, no risk factor, no evidence of active infection. That's a sign that you are ready to go home already. Don't keep this confusion. So basically she improved because we have the anti-inflammatory action as well in the NSC. Alright. NSC itself, it has this mucolytic agent, direct antioxidant, indirect antioxidant, anti-inflammatory reaction, also the interleukin reduction, okay, and also we have this antibiofilm because it almost like an antibiotic because of the antibiofilm. So all of this combined together in one medication improve the respiratory function, decrease the symptoms, fewer exacerbation, and of course fewer hospital admissions. Alright, we go into the guideline now. We have this gold guideline for COPD in 2023. Mucolytic of choice. This in COPD patient not receiving inhaled corticosteroids, regular treatment with mucolytics like NAC, reduce exacerbation modestly, improve health status. That's how our patient just now, Mr. NSL, even though interstitial lung disease, chronic disease, very damaged lung, he still have benefit from having prolonged use of the NAC. So this is the Flumasil. So thiol base, which actually help to improve the thiol just now we use for the production of the glutathione. Remember, glutathione is our antioxidant agent. Okay. Of course, this is a busy slide, but the key is we look at the medication comparing erdostin, NAC, and SCMC for mucolytic activity, antioxidant, anti-inflammatory, direct, indirect bacterial activity. So basically, only NAC you can see have effect on all the action, okay, compared to the other medications, right? So effect of NAC administration in 30 days mortality in critically ill patient. Now we're talking about ICU cases, septic shock, carbapenem-resistant Klebsiella, and also Acinetobacter baumannii. We have Acinetobacter baumannii, wow, we scratch our head. Very difficult because we need a combination of medication to work and it will take longer time to recover. So they did a retrospective case control study in 2021. Of course, there is a synergistic activity of the NSC with antibiotic in reducing 30-day mortality rate in ICU patients. So there is a study. It's not something that we just say from experience or by numbers. Okay, they did the proper research study on this and they realized that length of ICU stay was statistically significantly longer in cases than control. And also, we can conclude that studies suggest that combined use of NSC plus antibiotic reduce the 30-day mortality rate in ICU patients with septic shock. Because we know that septic shock patient, if they have organ failure, mortality rate 50%. They have 2 organ failure, mortality rate 70%. Okay, When they have 3 organ failure, heart failure, kidney failure, lung also not doing well because of ventilator, we can almost say that almost always patient may not be able to make it. Okay, so that's why it's very important for us to act fast and act properly, because we have to find it. We have to resort to all the resources available to help to improve the patient condition in a ICU setting like this, right? So 30-day overall survival rate, we can see that compared to the controls, the 30-day survival rate is actually higher in patient with the NAC. Better lah, higher to means better lah. The effect of NAC on biofilms, just now we talk about the production of the complex 3D biofilms in the respiratory tract. Okay, another busy slide, but it's okay, don't worry. Okay, don't have headache yet. NAC has good antibacterial properties and the ability to interfere with the biofilm because it dispersed the biofilm, it ruptured the biofilm, and also because of that, the biofilm disrupted, antibiotic works better. Okay. So there is significant enhanced symptoms relief on top of the antibiotic intake. Of course, flumacy itself will cause highly significant, okay? The symptom relief, you can see that it has improved significantly, almost 0. When we say 3 is actually very intense night and day symptoms. 2 is moderate persistent daytime irritation. 1 occasional sporadic coughing only, okay? So this is what the flumacy will do. Lesser symptoms and also occasional sporadic coughing only. Itu pun almost absent lah, in 10 days. Okay, just now we look into surveying COVID-19 data. In a way, COVID-19 helped us a lot in improving our knowledge on the respiratory tract infection because they did a lot of study after the COVID case. So, okay, I know this all, we have 2 cases, 2 pages of this, 2 pages of this publication study report. They did the study report lah, cohort study lah, observational study lah. But the important thing is the summary of these studies. You say that COVID-19 with the flumacy itself, hypothesis that targeting the oxidative stress agent, if we target with antioxidant like NAC, it improved the health. Okay. And then oral NAC 1,200 per day, which is usually we give 600 milligram 2 times a day, BD for adult dose. With pneumonia, reduce the risk of mechanical ventilator. Those who are receiving NAC in COVID patient hospitalized with pneumonia, discharged alive, significant shorter length of stay. So we can see a lot of improvement. Okay, and also treatment with NAC high dose. This is 3 times a day, can be given up to 3 times a day in very ill cases. Significantly lower mortality, despite this patient being older, more frequently male, and more comorbidities. So reduces all this. Remember, the glutathione lesser in comorbidities, elderly. By giving the NAC, it helps to improve the glutathione production, so lesser complications. Okay. So basically, this is just reciting the same thing. And then we know that, okay, we know this, effective, yes. Okay, we know the dose. Okay, how is it? Is it safe or not? Okay, we use for longer duration. Apparently, they did for the studies go back to 41 articles, okay? Given dose of 600 and above. So, when we see this patient, their safety profile was similar, okay? No change, no other complications, and most of the time they have gastrointestinal symptoms, some nausea, vomiting, bowel discomfort, okay? But it's actually normal, common than the control group. Even those non-receiving NAC also having the same symptoms anyway. Okay, part of it can be because of the infection itself, very infectious especially. So the GI symptoms is not even, it's almost non-existent to my patients at least lah. I'm not sure whether the patient is not telling me, but so far none of them complain of anything, right? But this is something that we need to know. Of course, medical, we are very, very transparent. We have to tell everything, okay? So with that, I think that's our last slide. Thank you very much for your kind attention.